Okay, 1, 2, 3. Good evening and good morning, everyone. This is a special podcast today from the Center for Management of Healthcare Services here at IIM Ahmedabad. Today, we are going to talk about the status on testing globally and locally in India. And we have some of the experts who are working at the forefront of this field, both in India and outside India. We are joined today by Professor Anup Malani, who is a professor of law and medicine from the University of Chicago. And along with him, we also have Dr. Manoj Mohanan, and professor at the Sanford School in Duke University. Joining Anup and Manoj is Dr. Anu Acharya from Map My Genome. She has done some influential work as a healthcare entrepreneur in the recent past and is one of the go-to persons to learn about what is the situation with testing today in India. Thank you, everyone, for joining us in this conversation.
Thank you.
Thank you. Good to be here.
So to start off, maybe I'll just start with Anu and then come to Anup and then go to Manoj. Just some broad thoughts, given these last 2 crazy, chaotic months we have had around the world and in India. What are you observing while trying to ramp up testing, sensitize on testing, and the role of testing both for symptomatic and asymptomatic patients? What's your general observation? So maybe Anup and Manoj can share some opening thoughts, and then I have some questions for all of you.
Thank you, Jonathan. So I think if you look at the world in general, I think we had a few phases of what happened with testing. We had the first phase where suddenly it was there were absolutely no kits available. There was a true shortage because supply chains were cut off. I think what this pandemic has done is to enable a lot of local innovation, and therefore the capacities in terms of the testing kits itself has been ramped up, including in India. I think we've ramped up very significantly in terms of what we had in the beginning of the pandemic to where we are today. Today, we are doing more than 1 lakh tests in a day. I think that's clearly something that has changed. But what has also changed has been the fact that there's been a lot of innovation in the testing kits itself. So you have not just the regular RT-PCR, you're starting to see a lot of other kinds of testing that has come up, whether it is a point of care testing, whether it's lamp kits or otherwise. So I think there's a lot of innovation which I think ultimately will be useful for the world overall. But at the same time, I think there have been the information or the way like how we react with other diseases. And unfortunately, I think COVID is slightly different. And I think that's where the big challenge lies. So we are seeing that a lot of the testing that is happening today is mostly around the symptomatic patients. And it's also around a lot of people that we would, that probably are already, going to the hospital, but we are missing out on a lot of different cases. And because it is such a, it is a very different kind of a pandemic. I mean, it's a very different kind of a disease. We find that we have to be much more careful in terms of how we choose the testing strategies for countries as well as for the rest of the world, because in the end we are not isolated, we are not islands. We do interact with other people.
Anup, you want to take over from Anu's opening thoughts and share your perspectives?
Yeah, let me add 3 things, I think. The first is there's a close connection between testing and policy, and sometimes in a fruitful way, sometimes in not fruitful ways. Ideally, testing should give you information that should guide policy. The problem is that when people know what results from testing lead to which policies, and they don't like those policies. So for example, if you find lots of test results, you're going to have a harsher lockdown. That gives people incentives to sometimes not test. And that's a real challenge because first we need the information to make any good policy, and ultimately lives as well as economic activity are on the line. But the problem is knowing what is the consequence of testing leads sometimes people not to test, which is something that we hadn't anticipated, but is an important dynamic. Second, I want to pick up on something that Anu said, which is the importance of knowing who to sample, that is to say where to sample, who to sample, when to sample. We call this just a sampling strategy. That's got to be very much connected to what you're trying to do. In the early phases of infection, if you knew a little bit about what's going on and you really thought that you could trace and isolate and stop the disease, you'd have a different strategy than once you know that there's community transmission. then you want to test in a different way because your policy is going to be a little different. It's more, for example, having social distancing measures or travel restrictions. So that's something that we need to, I think, talk more about and make sure people are aware that you want to, as Anu said, not just test the symptomatic, test the asymptomatic as well as the disease evolves. You also want to think about where to test. Obviously, different places have different rates of prevalence. High density, low density areas are different. The third thing is knowing when to test and the importance of repeated testing. This disease the prevalence will change over time. It'll rise and then it'll fall. And then if you think about people that are recovered, that will just rise and hopefully get to a herd immunity level if that's the strategy we're pursuing. In that context, we have to test periodically. Maybe once a month, a cross-sectional comparison is important. The last thing I want to talk about is just interpretation of the data. I think there's still remarkable confusion about the difference between antigen and antibody tests. Between tests that are checking to see if you're currently infected versus did you have the infection, are you now recovered and perhaps immune? I think doing that interpretation is important. There's lots of important parameters that we need that are still not estimated, both because of lack of testing and also lack of data availability, that is to say, sharing of data. I think those are the things that I would add to what Anu said.
Amazing. So you are talking about keeping in mind testing and policy, the sampling strategy, and the interpretation of data. Manoj, I know it's always a hard call to come and in the end with some opening comments, but I'm sure you have some. So why don't you take over from Anup and share some perspectives here? You have to unmute yourself.
Sorry about that. The easiest way for me to start is just say what they said. I mean, Anu and Anup and I have clearly been working on a number of things together and we fully agree. Two other things I will add. One is, just as policymakers react in sometimes predictable but also surprising ways given the misunderstanding around test results, similarly, there are issues of stigma. And from a social perspective, there's the very parallel issues is we would like to start testing people and give them some information about their test status. But although right now with zero prevalence, for instance, it can be a positive result. If I know today that I'm immune, it would actually be good news for me. But conveying that in a way that's understandable, especially given all the fear that has been now generated around COVID, is considerably challenging. And so we'll need to think hard about how that sort of environment needs to be built, how that communication is given. But I think it alludes to this point that both Anu and Anup had made, which is there's different types of tests and there's different types of people and different types of sample. But in any given epidemic, as we start going along the continuum from early stages to somewhere in the middle towards later stages, the types of tests we want to do are different, right? It's not true that the same tests we do at the very early stages of the tests or even strategies for policy at the very early stages cannot possibly be the same ones at a much later stage of this epidemic. So let me pause there. I'm sure you'll have other questions for us.
Okay. I'm very glad you brought about the issue of stigma because I am working, as you know, on some destigmatization paper as well, but in a different mental wellness context. And you're absolutely right that communication is the right way to communicate and get it endorsed by suitable influencers probably will play an important role. What's your assessment? You guys have been working also on the testing infrastructure by states within India. What's your assessment here of what's happening in India? Where are the success stories? Where are the challenges? Broadly, what would be, you already have hinted at being agile about the testing policy state by state over time. Now that we are going into this paradigm of living with the virus, so potential super spreader events will crop up, given that airlines are opening up and universities are opening up, etc. What's your assessment of where were we? You have given some numbers that we have done well, but where should we be going forward in our testing infrastructure and policy in a more practitioner way? I mean, it's lovely to start off on a theoretical note, but it would be nice to start off in a practitioner way, your recommendations to India and different states. Anup, you want to take that up and then we can go to Manoj and then go to Anu then, if that's okay with you. You have to unmute yourself, Anup.
Yeah, I'd be happy to. So a few things. I think that there are some states that have done a laudable job of both testing and reporting. I think Kerala comes to mind, thinking both about the need to immediately begin testing, think about why you want to test different places, thinking about, importantly, the logistics, like how do you get people to testing centers. I think they did a great job with this. They also had a website where you can get the data very clearly. I think another state that's done a great job is Maharashtra. Their reports have strongly influenced thinking about the disease throughout India, and research as well to help us understand. Other states have done a laudable testing job. Andhra Pradesh. What we'd like to see, though, is kind of sharing of the data. Whatever happens in one state is important for other states, and we would have liked to seen that a little bit more. It would have been great if there were more state-led initiatives in this regard. But those are laudable examples. I think we learned a lot, in case there's another event. In terms of super spreader events, I think that's a very interesting question. There's this debate going on right now about whether or not the transmissibility of the infection is roughly constant across the population, or whether there's certain individuals or events that have very high transmissibility and then are responsible for a large percentage of the infections. This has been something that has been very hard and a hot topic in academic circles, and is now getting to the press as well. The real challenge in this context is knowing whether it's certain individuals, either because of their biological situation or their connectedness, or whether it's certain events. We're still learning. The reason why it's important to know is to see if we can stop it. So it's one thing to know ex post, these are the things that were responsible. What's much more helpful is to know ex ante, these are the types of individuals, or these are the types of events that we want to avoid. So I think thinking about things like airline flights, bookings at train stations when everybody wants to go back home to their home state, those are the things that are, I think, are predictable, at least to say, there's a chance that these super spreader events are really the problem, and we should avoid them. There also, when we think about policies of social distancing, there's some policies that look like they're social distancing, but are exactly the opposite. The example we like to use is shortening store hours. That seems like a really good idea because you're not going to have as many people at the store. But the problem is, if the demand for that store's products is the same and you shorten the hours, that means more people are going to come in a shorter number of hours, and you're going to have more contacts. So we need to just change our thinking. The question really is, imagine playing a global game of tag and you're not it. How do you avoid being tagged and being made it? That's the mentality we need to have. Let me stop there, because I'm sure that Manoj and Anu will also want to add.
Manoj, you want to chime in?
Absolutely. This is a great start, because Anu was telling us about some of the success stories and how some states have been sort of the front runner and others have been trying to catch up. The interesting thing in this context is, health has traditionally been a state subject. So you would expect that states will have a lot more heterogeneity. That's expected. And in some sense, what we would have liked to see, and even in this setting, is that the states have the ability to respond based on their resources and problems and stuff. A challenge that has happened in this particular context, especially around the issue of testing, is that we are in completely uncharted territory. So this is an unprecedented event. Nobody had thought about this. We responded with a policy that has the center making decisions, which makes sense in the early stages, right? The challenge, however, is how states respond to that. Are they able to accommodate their own ideas about responding and stuff? Where it sort of the rubber hits the road is in the early stages, we saw that when the antibody test came along, states did try to adopt it and implement it. But as soon as things started going wrong, then they had to hold back. Right? And that was in response to the center saying, let's not do it. So when we think from a political economy perspective, you're supposed to respond, but you don't have the freedom to respond either from a state's perspective. So that's a huge challenge. Already what we are seeing is, as far as RT-PCR, which is a test we would want to use to test whether somebody actually has the virus or not, that has become much more available now. As Anu said, capacity has gone up. We are capable of doing a lot more. But as we go along and a sort of different dimension of this epidemic comes along, and we want to know now how many people have actually suffered from the illness, or actually more specifically, have had the infection, regardless of whether we've seen their symptoms or not, and how many of them have developed antibodies. And so if we cannot use the tests in a very expedient manner, make expedient decisions about what testing technology is appropriate for the state, what can they afford, what can they deploy, it would become very challenging. And so that kind of efficient decision making is one of the challenges that states feel. And to some extent, even in the op-ed that the three of us wrote earlier
Right.
today, along with Sachin Balsari from Harvard, one of the things that we try to point out is that as we go along, we need to enable states to do more of testing that's appropriate for the asymptomatics, the seroprevalence type of studies. So that is one of the key challenges right now, in my opinion. I'm sure Anu has more to add as well.
And Anu, perfect time for you to chime in. And it would be nice to also know from the diagnostic ecosystem, medical devices and diagnostic ecosystem in Bangalore, Hyderabad, what kind of stuff is happening on innovation and science here? Not just for India, but potentially tomorrow exportable to the world if there is something going on that front. So, yeah.
Definitely. So I would say that, in addition to all the points that both Anup and Manoj have mentioned, I think one of the challenges that most states had was that we are in the midst of a lockdown. You couldn't go across states. So if you look at a normal diagnostic regular testing across the country prior to the pandemic, I think we were all used to having the large labs come pick it up at our homes, pick up a sample and go away, right? It was a very well-oiled machine. But when you suddenly come across to a pandemic like we are in today, the problem was that you could neither go across the states, so you have to build capacities within your own states. And I think that was a big challenge that most states had to face. I think many states, for instance, AP had probably one government lab that was able to do that and had no private lab that was actually officially accredited to the state. So from there, they had to ramp up very, very rapidly to more than 15 labs. So I think if you take, different each of the states, for each of them, most of the states did not have enough capacity in the beginning. And from there, to build it up during the lockdown was quite a difficult challenge for most of them, right? So I think, there is not just a question of buying machines. There is also the question of talent availability. There's a question of, RT-PCR is not a simple test. There are lots of different pieces of that whole test that needs to be, properly made sure that, every piece works together and properly. And because you have, first is you have to get the samples in, it's a nasal swab. It's not an easy thing to do. So you have to have somebody trained to do that. Then you have to transport it. If you don't have an agent that will allow you to keep it transported at room temperature. So you have to make sure that your collection, the transport is absolutely seamless. You have to make sure that once it comes to the lab, that you have to extract your RNA and you have to have all the biosafety conditions. Now, normal labs, normally I think you did not need all that because everything would go to a central lab. Now when you in every single city or every single state, it becomes very hard because suddenly you have to build up, biosafety level 2 in every lab that you want to test in. You have to build in the capacity to extract RNA. Most of them do not have automated machines and so on. So I think this was quite a tough challenge for many state governments. But I think they have done a fairly good job of being able to ramp it up. I guess not everything can be built in a day or a month. And therefore, for the future, I think it's important that the infrastructure that is built today can be used properly in the next, if there was anything in the future. Now, we did have a few instances of like the H1N1 in 2009-10, but was not anywhere close to this level of infection. And as a result, I think the preparedness at that point was quite low compared to what we are seeing today. So I think the fact that we have gone up to more than 600 plus labs today that can do viral testing and probably go up to 1,000 very soon, I think that will be a good thing. But we have to make sure that these can remain, make sure that we have the right kind of people that are operating these. But also see if we can use some other automation that can be done so that we don't have to depend on individuals. Because ultimately we want to make sure that the processes that we are using can be fairly, much more streamlined across the country. So that would be what we are doing with the RT-PCR tests. Now, you mentioned the newer tests, newer technologies that are coming up in the world. There are several, and I think we will start seeing a lot more, which will be the point of care kind of results, where every doctor will be able to do that in their own premises. So I think we'll start seeing slowly a trend towards that. You would also see a lot of tests like the CRISPR-based tests as well as LAMP-based tests. And these are very simple and very inexpensive. And you don't need the kind of complicated, equipment or personnel that are needed for the current RT-PCR tests. We've also seen that there has been one antigen-based test that was approved by the US FDA on an emergency basis. But again, currently a lot of these tests that I'm talking about still have issues on sensitivity and specificity, but over a period of time, I think these will get better. So I think one of the best things I've seen about this pandemic, although I shouldn't say anything is good about it, is the fact that we've been able to very, very quickly develop newer diagnostics. And I think all that has been possible because of sequencing the genome, not just by the Chinese scientists that first did it, that allowed a lot of initial kits to be developed, but it's also starting to see that there have been hundreds of genomes, even from India, that have been submitted to the GSA and so on. And all of that is spurring a lot of innovation today. We've also seen that India is today able to now get RNA kits that are being validated. We are getting the master mixes. There are more than 20 companies today that have already developed kits. So I think these are all very good signs. I think the good thing would be if we can actually see this, make sure that these can be certified by international or Indian companies, and make sure that we don't just create this for something for India, but make it in India to make sure that we can export it to the rest of the world.
Amazing. These are great thoughts, especially on the operationalizing aspect as well as the science aspect, the genomic science aspect. I was reading in the news today that monkeys have run away with test samples in meat, right? So now we know it's easy to be like, you can crack a joke about it, but it's not at all easy to do this. It's not a normal disease. And I'm also heartened by the fact that you're saying science and technological change is changing globally here. It would be nice now to segue to a conversation that we just highlighted about certification, because ultimately, and this goes back to Manoj's point on stigma, testing is one part of the story. The rest is tracing and isolating, right? And then we come to the conversation of how do you do it? Brick and mortar tracers, app-based tracers, all kinds of debates around privacy of these apps, mandates by different types of governments. So Anup, why don't you take up the not so easy task, if I can say that, of sharing your thoughts as a law and medicine professor on the ethics and the quality certification part here, and how should a regulator work here globally and locally to handle the uncertainty in the process, because it has these complementary mechanisms as well of tracing and isolation that is only going to result in a fruitful normative application of dealing with COVID-19. So you want to start there, Anup?
Sure. So I'm going to focus on the certification to go back to work. I assume that's roughly what you're talking about.
Yeah, that's fine.
Yeah, in fact, we just had a Washington Post op-ed out with a colleague of mine, specifically talking about immunity passports, which are very much in discussion in the United States as well. So there are a few issues here. The first issue is making sure that it's clear that this is a certification and not a passport, in the sense that we don't want it to be the case that people will not hire individuals who are not certified until our testing capacity is up to speed. We're not going to be able to do that in any serious way. So most people are not going to be able to be tested. And so that's something to keep in mind. It'll be the most valuable workers or the wealthiest individuals that will be able to get the certification unless we specifically plan otherwise. The second thing is making sure that we understand what the meaning of certification is. I think there's confusion on both sides. On the one hand, people are worried about the quality of antibody tests. So that clearly we're talking about antibody tests here because we want to know if you're recovered. So one is the issue of the quality of the antibody tests and what the interpretation of those tests are. So for example, knowing that what you need to see is IgG but no IgM, not just any antibodies will count. Having IgG but not IgM will indicate that you've actually fully recovered and viral load is down so that you're no longer infected. And then understanding that the test can be imperfect. But not thinking too much of that. I think that in some sense, people see that it's imperfect and then decide not to do the test. An imperfect test can be useful, but you need to understand that what the level of imperfection is. There are also methods of reducing that risk by having two different types of antibody test, for example. So if they're independent samples, that can reduce your sensitivity and specificity errors. Then after that, there's the issue of knowing this discussion about whether or not there's potential for reinfection. Again, this is something that we just don't know right now. We often hear reinfection, and then we hear that a lot of cases, those were false positives. So I think that there's still uncertainty. Do I think that it's based upon thinking about other diseases and just general theory on immunology? Do I think it's a good idea to have evidence of recovery before, not before you go back to work, but should I think of recovery as having some degree of protection? I think the answer is surely yes, even if there's uncertainty about it. Then there's the issue of complications associated with it. So there's, the way that you're going to track people. So this is different than tracking and tracing. You can allow people to go to private centers that are certified, then they get a certificate that says I'm recovered. Make sure that it's matched to the individual, but then the person should be able to walk around with that. You don't need a centralized database for this necessarily, as long as you've got certified facilities that issue that. It's just like licensing for a job, for example. I think that's an important thing to keep in mind. The one issue that you have to be worried about is if people use certification as a requirement for getting a job, or we don't allow people without certificates to go out, there'll be a strong incentive for people to self-infect.
Yeah.
Which is reverse incentive, and I think that it's something that we have to keep an eye on. But part of that is just what we do. If we say that you can't work without a certificate, that's where you're going to have a strong incentive. But if we allow this to just be information that's out there, I think there's a little bit less of an incentive to do that, but still something to keep an eye on.
This is not easy at all. Manoj, you want to take over and say how you can do it in a country like India? Because I can feel like challenges here. You have to unmute yourself.
That's extremely, sorry about that. It's extremely hard to do for all the reasons that Anup said, multiplied by, a few 100 million more.
Yeah.
And I mean, everything from how quickly can we possibly test people, and how, I mean, we work in a setting where, even something very basic that we take for granted in many other parts of the world, like having a driving license, is not easy to implement and enforce correctly. When I think about if we were to impose a restriction in India that you have to get a testing done, apart from the ethical kind of dilemmas that Anup mentioned, then there's, I'm sure there will be people trying to get around the system, the forgery that comes with it, and the bribery and all of that. So I think this is going to be, it's important to do, but very hard, I think, to implement in a country like India. And frankly, I haven't thought about it as much as Anup has, but it just is daunting. The very idea of that is already daunting. So there's that issue. And then the other part is, some states might be able to do it better than others. And that heterogeneity in India is always going to be a problem. So tomorrow, if, say, Kerala is able to get
the entire population tested,
does that mean that now I mean, I'm originally from Kerala. I would love it if you tell me that you're going to only hire Malayalis all over for everything. But I don't think it can work politically till we figure out the problems for even relatively low resource states. That's going to be the challenge in there.
Anu, your time to take up the challenging task here and say something that's operationalizable, I suppose.
I guess in one of the ways that can be done, and I think in some ways it is already starting to happen in some sectors, right? So if you look at what Karnataka is doing, they are asking for testing to be done before you board a flight. Right? Now, while currently I think that is more for RT-PCR testing, I think over a period of time we can maybe it will probably evolve to say that you can do a serology test or antibody test and then be able to, so you're recovered and maybe you're probably a little bit more safer. You can still use all the social distancing and other methods, masks and everything else, but you can still do. So similarly, I think, and they're doing that also, I heard, for hotels, for instance. And that way, I think if we start doing it slowly for each of these sectors that are there, it is a possibility. And I think from a corporate's perspective, I think it's very important. And so most corporates, for instance, are very, very, they're worried about whether there will be infection spread. So they are also very keen on getting tests like these done. So I would say that it will happen, and it will happen slowly. And once it happens over a period of, in certain segments, we will be able to start seeing that can be replicated. And it is not something that is, I think getting a antibody test is actually not really a bad news for you, as Manoj pointed out earlier as well. It is something that people will be happy to get. I mean, I did mine and I saw that I didn't have. I was very upset. But if you do have antibodies, I think it's a good thing to have. But at the same time, I think there are lots of execution challenges. But I would say that in certain cases, at least in the private sector, people who want to get back to work, employers that want their employees to get back to work, I think that will happen very quickly in sectors that, for instance, whether it's delivery, whether it's other places that can be done. I think for most government employees, I think if it's made mandatory or paid for by somebody, I think there will be a possibility that it will be done. So I think it's important in India to find out who will pay for it, what are the tests that we are going to do, and how are we going to slowly open this up. Just like we are, the lockdown has now suddenly eased quite a bit, and more people are actually mixing. The traffic in Hyderabad, at least, is coming back to same levels that it was, earlier. So I don't think that is so. Given that, I think we need to make sure that there are some ways of either looking at a combination of testing possibilities and being able to make sure that we are able to very staged in different stages. We are able to slowly ease it down without infecting too many people. There will be some, obviously.
Yeah. So actually, the point that you said about you have tested yourself gives me the opportunity to go to the next question, and then we'll have the last word from all three of you. So not every city or state can do a Wuhan. I mean, Wuhan just did testing of everybody 2 days back, and we of course can debate about the false positives and negatives there. I saw in the news that IIT alumni are setting up a big testing lab in Mumbai. Now, if it is not being facilitated by either the social planner, local, global, central, and yet there are market incentives, like you say, corporates have an incentive to buy and purchase and implement it, like Anup was saying, for an ordinary household, like from the city I am from, Ahmedabad and Gujarat, and if we are concerned about symptoms, how do we proceed here in terms of, I mean, we will have listeners here on this call who would want to know, how do I get tested in a place like Ahmedabad? What's your general recommendation of how to proceed on this? Go as per the local state guidance? Is there some private mechanism to access? It would be nice to hear all of your thoughts here in general. And Anu, you may want to take that up because you are probably closest to the field, and then Manoj, and then we can come back to Anu also in terms of some best practices happening in the US potentially.
So I think one of the biggest challenges today is that most of the private labs are not allowed to test walk-ins, right? So if, let's say, somebody just wanted to do a test, they couldn't do. I could do it because you're testing out the kits. But I think that is being one of the biggest challenges, right? So for any other test, you can pretty much order it in your house and you'll get it. Unfortunately, it's still very regulated. And I think in the beginning it made sense from because of the scarcity of kits. But I think now, it's very important to engage with the rest of whoever has the testing capacity, as long as they're following the right protocol and they are accredited and all of that. I think that will open up a little bit of, it will reduce a little bit of the fear that is there in a lot of the, citizens in the country today. I think it's very important that we allow that to happen, so that, there are people who are genuinely worried about whether they, are
asymptomatic.
They are either, currently are infected or they've already recovered. I think if you start to see that there are a fairly decent number of people who are already recovered, I think it's a good thing for, for the society and the community that they live in. So I would say that that is not yet happening, right? But at the same time, I think it's the state's privilege and authority to be able to say whether they're going to allow that or not. So I think in the end, it will depend on individual state governments to be able to create policies that can allow you to be able to do that. From the center's point, I think they are currently allowing these kind of testing for asymptomatics for certain research studies. They are allowing for certain types of, so it has to be a study that falls under certain criteria that makes it, that allows us to be able to do something like that. But at the same time, I think once we ascertain that we have enough testing kits in the country, I think it should be important that this should be allowed to be extended to private labs and others, so that I think it'll ease out some of the capacity constraints that are there in many of the other parts of the testing labs and the government labs, and it will also reduce some of the fear that is there.
Perfect. Manoj, unmute yourself. Yeah.
So just building on Anu's point, I totally agree that the constraint right now is like a regulatory issue. I mean, even if we solve the capacity constraint, the regulatory constraint still remains. But I think it's also useful for employers and bodies like industries commissions and others, or trade commissions even, to start thinking about what is it that we're trying to do with testing, right? So if I had a large firm with thousands of employees, do I necessarily want to do only serology tests? Do I only want to do RT-PCR? What is my strategy? And one way to think about it is, you could think about testing that will help me divide my workforce into 3 buckets. One would be people who are already previously infected and now have immunity passports, or at least some antibodies, like Anup was telling us about. We know that those guys don't necessarily have to be considered high risk at this point. There are others who are probably infected, and we want to be careful around them. And the third group, which is the susceptibles who are not yet infected. If you can identify that group once, right at the very beginning, as we are opening up, it gives me some strategy to think about how to work with my workforce. I'm not sure we have a ready one-size-fits-all recommendation, but knowing that there are these 3 stages and people are vulnerable right now, there are others who previously been infected and there are others who are currently infectious, is extremely valuable to think about how to use my workforce, right? And that is information right now we are not able to use, even though states are trying to open up. We're trying to open up industries, we're trying to open up factory floors without knowing this kind of information. That would be, I think, if we can solve the regulatory challenges around that, the capacity, as Anu said, is already building up, and we might be able to solve that to some extent even better.
I'm glad you said that, because I think institutions like IIM Ahmedabad have a role to play here in terms of influencing policy and industry thinking here. So Anup, you want to take over from what Manoj said in terms of for an ordinary household in India, who potentially is different from an ordinary household in the US? What's your recommendation for getting tests done going forward?
So I'll tell you the policy I have in my household.
Sure.
Because I think it would be the same elsewhere. So the important thing to remember is that if any one of us is infected, likely the rest of us is infected. If any one of us is recovered, likely the others had the infection and are now recovered. So if you're trying to economize on tests, what you just need is one person getting tested, and then rotate who gets tested periodically. So this month I'll go, next month my partner will go, the next month our children will go, one of the children will go, and things like that. And that'll just help you economize what's going on. Now, the thing that's a little bit complicated is if there's certification issues, one of us needs the certification in order to be able to show up at work, then you got to change that around. It might be that anybody who's working has to get certified quickly just so they can continue working. But that's the approach that I would take. The important thing to remember is that we're very likely to have very similar test results. So that's the recommendation I would make. If I could just jump and kind of like reiterate some of the things that both Anu and Manoj just said, I think it's really important to understand that the in the initial response to the epidemic, the private sector wasn't asked to play a major part. In this second or third phase, whichever number you give it, the private sector is going to be critical. In order to scale testing, you need private labs and private industry to provide capacity and capital to do this. And the government shouldn't insist on only one process. They should certify different types of processes whenever they meet their qualifications, but it should be a certification process rather than an obstacle to get involved. Because the thing is, the slower we roll out industrial activity, economic activity, the worse, the more the economic lockdown, the longer its effects will be. We need to get people back to work. The private sector is going to be the quickest to do that. They're also going to be pretty good at coming up with kind of innovative solutions to solving the logistics problems, getting supply, finding new testing processes, and things like that. In fact, there will be new labs that might even enter the marketplace, or lab facilities that will grow. And I think we ought to enable that. India has a thriving economy, but that economy is a private sector economy, and testing is no exception. The other thing I think is really important in what Manoj said is that once companies understand how basic disease dynamics works, they realize that there's 2 things they need to pay attention to. One is testing. Manoj talked about that. But the second thing is another more subtle thing that Manoj mentioned, which is staffing. So how do you keep your staffing in such a way that even if you have a few infected people, you're not going to spread the infection very much? And that is to say, either keep a very high, kind of spread out the recovered group folks, or isolate the susceptibles, things like that. I think HR companies are going to play a very important role here in helping think So beyond labs, I think that'll be an important industry that we'll see in the coming year. The last thing I'll tell you is what will make me really, really happy is that in a year from now, we go around and we find that there's almost no demand for testing. And the reason is because we've hit recovery, so that people are like, well, you're recovered or not, we still think that we're kind of got herd immunity, so it's not such a big deal. To me, that's a good outcome that we'd like to see in a year.
Yeah, and in a year, hopefully there are pills and vaccines. So to take care of this in a exposed sense. I'm very glad you mentioned about these three approaches, Anu. And the fact that you are taking the lens 12 months ahead, because monsoons are coming in India. People are starting to talk about this becoming endemic and syndemic, etc. And the other day I was chatting with someone from somewhere, I'm forgetting exactly where, but people were talking also about, actually with German colleagues, they were talking about SARS-CoV-2. So time for the last word. What have we learned as societies, as individuals, as researchers in developing economies, in developed economies from SARS-CoV-2 related to testing, and also on the issue of regulating, tracing, and isolating for the purpose of catching the disease and also for the broader purpose of the implications it has for the economy? Anup, you want to start there and set the stage, and then maybe Manoj and Anu can chime in to add to your points. What have we learned from SARS-CoV-2 for SARS-CoV-3 if it comes back to us?
So lots. The first thing I think is the countries that have that went through the SARS epidemic in the early 2000s actually performed quite well this time. And the reason is because they went through a trial run before. And so we need to view this not only as a crisis to deal with now, but as a learning opportunity for COVID 2.0. If it never comes, but if it comes, we should be prepared. And actually, Manoj and I have talked a little bit about this, what we'd like to see. And so here are some of the ideas. The one idea I think that would be helpful is that India ought to take seriously the idea of wargaming for future disasters, including pandemics, and then train a cadre of people who will, when an emergency is declared of a particular type, whether it's an environmental disaster or it's an epidemiological disaster, they step in and they make decisions. And so there's less policy paralysis at the beginning. That framework should be set up for next time, whether it's tracking and tracing, whether it's social distancing and larger quarantines or something else entirely. And the same thing ought to be done with the medical establishment. Think about how you quickly ramp up testing, how you're quickly going to ramp up medical research to be able to find solutions. To some extent, we know this is possible in India because I think that Kerala's response is a byproduct of its experience.
Nipah.
Exactly.
And floods, probably, yeah.
Exactly. And I think we need to take disaster management very seriously. And then in the moment of crisis, actually shift control over to the people who've been trained and practicing, not stick with the old approach, because the old approach is not appropriate for the short time period during which there's an emergency. That is an important political decision that has to be made ex ante and that people expect to actually happen. Beyond that, I think that there's a lot of we should do an autopsy to figure out why we were slow on testing and try to avoid these sorts of situations. Examples are, for example, the confusion created by the early Supreme Court opinion on whether or not you can charge for tests. Yeah. That's something that was a stumble that we could have avoided. Thinking about super spreader events, that's something that we could probably avoid, things like that. There's a few more examples like this that we should just immediately write down on a list and say, I'm not going to do this next time. And here are the things that did work. I'm going to do this next time.
Amazing, amazing. Anu, we want to take over from Anup, and then I'll let Manoj have in with the last word, technically the last word. That's okay.
Sure. So I would say that there are 2-3 things I'd like to point out. One is that, innovation doesn't happen only when there is a crisis, right? And I think when you think about whether it was the HIV treatment, it was scientists thought about retrovirus much before it actually hit us. Same thing with when CEPI set it up for vaccine development. I think you're preparing for a disease X. So in the case of testing, I would say that it's extremely important that we look at multiple levels of preparedness from our side, at least in wherever we can. One is that we are obviously looking at the genomes that have been studied, and I hope that there'll be a lot more studies on the genomic aspects of what the virus does itself. But the second aspect is to look at the genomics of the individuals to whom it's spreading. Who are the super spreaders? Why did it affect? I mean, why is it that some people can spread more faster than the others? Second is that we look at comorbidities. We know of some, but maybe we can, if we do a large enough study, we can understand the risks better. So that would be another thing we could do. Another thing, the second thing that you can do, I don't know which number I am, but
That's right.
to be able to simulate and see if you can look at the genome, see if there are other possibilities of other kinds of viruses coming up and see what you can do about them. So I would say that it's very important that we create an innovation platform that is encouraging us to be able to study these in much in advance. The third thing that we can do potentially could be to be able to take all these samples that we have, of positive samples, but be able to do a long-term study over them, right? So for instance,
Mhm.
you have the blood samples that are there, you create blood, the repositories for them. If you're able to get, some of the other material that you can store over a long period of time from the swabs, then you're able to use that material, be able to study not just what happens to that, but also to be able to study what happens to these peoples over a period of time. So I think doing a long-term study with the objective of saying that this is not just for COVID, but to be able to understand, multiple levels of medicine, multiple levels of how it spreads and all, I think would be very useful. But there are many more ideas that I have.
Sure, sure. Of course, we are all scholars and we are thinking about writing papers as well on this. So I'm sure we are wondering about what's our next article around this discussion. Manoj, why don't you share your thoughts on preparedness learnings for
Sure.
tomorrow?
And I want to just echo and completely support what Anu said. We need more research. We need to give researchers more data. The ability to
Absolutely.
innovate. I mean, of course, it's music to our ears as academics, but in this specific instance, one is especially acutely aware of the need for quick innovation and research and evidence and stuff. But let me use that to sort of also pivot to the point I was going to make initially, which is one of the things that we have had as a peculiar case here in this particular response is countries have to respond to their own problem. And so just if you take Anu's point very seriously, that the genome sequencing and understanding the virus, and maybe there is mutations and the different types of viruses have been able to spread around in different parts of the country. And that is an issue, very serious, because if we don't know that, then essentially we are responding to the problems that our neighbors or countries in some other part of the world have.
Yeah.
I say this in jest, but if you think seriously about it, much of India's response, and not just India, this is true of many countries, but I mean, we're talking in India, so let's talk about India. Much of India's response was sort of a reaction to what we were hearing about the epidemic in New York or Italy at the time. What we have not been able to do is to say, hold on, let's try and respond to what's happening in India. Let's take a quick pulse, learn about it, which is all about the testing, the data, the understanding, through research, the genome analysis and whatnot. We're not able to do that. So next time around, if we can try and think about what happens if a COVID 2.0 happens, God forbid it doesn't, let's have the surveillance systems. Everything that Kerala had was because they were prepared. They had the war rooms, they had the surveillance systems, they had a response strategy in place so that they could see what was coming their way and then respond to that. Hopefully we'll be able to do that. And in order to get there, in addition to the disaster management expertise that Anup was talking about, and I want to reiterate, it's not that we don't have some very good people in India, we do. But India is, if we think about it, 1/6 of humanity. By that account, we should have probably 1/6 of all disaster management experts in India as well, because God knows we get more than our fair share of disasters here.
Yeah.
So we should be investing a lot more, but that has been hard to do. And so next time around, if this comes around, let's hopefully have more disaster management expertise, but also invest a lot in our public health systems. Whether that's training, whether that's investing in public health systems that can help the states respond in a better way. And that doesn't mean to take away anything from the private sector. Like testing can be done by the private sector in a very good public health system as well. So those are two distinct issues, but let's not spend too much time on that. That was the main point I was trying to make.
Yeah, I was reading this article on BBC last night by Sautik Biswas, which is citing this study by Parikshit Ghosh at Delhi School of Economics and his co-authors about what's coming. And I noted very interestingly that he was quoting epidemiologists and immunologists, but under condition of anonymity. So it's amazing to think about India creating a 1/6 level of architecture in science and innovation to deal with tomorrow, we also have to have that enabling environment to face the data, to endow the scientists, to document what is causal, what are the facts, even if these might be problematic for policymakers. And hopefully everyone who is listening to us is going to take that also, in addition to the learnings that you said, for tomorrow's disease disaster or more broader disasters that may strike the country. Thank you everyone for the conversation that we had today. I really appreciate Manoj for coordinating with Anu and Anup for the timings. Anup, thanks for joining in from Chicago. Manoj, thanks for joining in from Bangalore. Anu, you're joining in from Hyderabad. This should be helping our community locally and globally, and we look forward to being in touch. I wish you all the best. Hopefully we'll be having you on campus, and please stay safe.
Thank you. You as well.
Bye-bye.